everybody, for coming. That's one thing you don't say to the audience, by the way. You leave that to the program manager or the organizer. So I'm going
Right
to,
now, right now,
huh?
I am the fictional program organizer, and we're going to launch right into our program. My name for the next 15 minutes is Susie Beef. I got my beefs on here, and I am the president of the Coalition of Business, Agriculture, and Commerce of Southeastern Oregon. This is a new, young organization interested in better policies for the people with strong roots in moderation. We have invited Michael Huntington from an organization called HCAO, Healthcare for All Oregon, to talk with us about the issues and the policies there. He's brought a slide presentation to us. So I think without further ado, I think we should just turn this over to Mike to do the presentation that he said he would do for us. So Mike, please take it away.
Thanks, Sandra. This will be
Susie, my name is Susie. Susie Beef.
Susie. Thank you, Susie. I'm going to let people see how we use Google Drive here, since I need to pull up that, fellow Oregonians. Oregon stands at a pivotal moment for years. Our state has been a pioneer in healthcare reform, inching closer to comprehensive coverage to all of its residents. Today, we are nearing a major change in healthcare for Oregon that could serve as a model for the nation. The concept of universal healthcare is not just a dream, but a tangible goal that Oregon has been steadily working towards over the past 3 decades. With the establishment of the Senate Bill 770 task force in 2019 and Senate Bill 1089, the Oregon Universal Healthcare Plan Governance Board in 2023, we are closer than ever to making equitable, affordable, and comprehensive healthcare a reality for every Oregonian. As we explore this critical issue, let's consider the values we cherish, the progress that we've made, and the challenges we face, the immense potential that universal healthcare holds for our communities and our future. If you were one of these patients depicted on this slide, what kind of a healthcare system would you trust? What would you want the system and your care providers to value most as you receive your care? Anybody from the audience? What? Just a few seconds. What would you want if you were one of these patients? These are the values expressed by Oregonians that a Healthcare Value Hub report published in August 2024. Those of us at the annual meeting in June heard these people speak about this. And you can go to this report either with the QR code or the bit.ly link there. So basically, the values are Oregonians want healthcare that's universal, equitable, affordable, high quality, and easy to use.
Who is this group? I just went to their, the QR code, and it's like, who are they?
They are a nonprofit group that studies just what they say in their title, values, Oregon values. And I don't know their origin or how they're funded. But
Okay.
they did present at our meeting in June, at the statewide meeting.
Yeah, I'm asking as if I were just a person in your audience. So I know who they are. Okay.
Yeah, audience members, we got to engage this guy.
Yeah.
So, what percentage do you think of these people that were assayed or were on the poll supported the idea of a universal healthcare system that would fulfill those values? 25%, 50%, 75%, 100%? Anybody?
60%.
60%. Do we have an upper?
70%.
Getting closer. Isabel, Karen.
100%.
100%. Okay.
Here we go.
There, okay. So, 75% said desirable and achievable, or just desirable. What percentage of those who said desirable said they would accept taxes equivalent to what they are currently paying through private insurance?
65%.
65%. Okay, let's see. Oh, wow. Now remember, these are people that already said they favored universal health care. Of those, 81% said they would accept taxes equal to what they're now paying in premiums and out of pocket.
That's pretty high.
Yeah. So what's keeping us from having a universal healthcare system? Anybody? Any ideas?
Insurance companies.
Profits.
All right.
Political will.
Political will, yeah. Or won't, yeah. Anything else? Okay, well, hey,
Misinformation.
Technical problems at a state level.
yep.
Yeah, right.
State level problems, misinformation. But no matter what audience I think you're talking with, some would start with equity, but it all gets back to cost.
All
So,
the money.
yep. So, we pay about double what other countries pay, and you all are aware of that. As you can see, it's off the screen for us here a little bit. If I pull it over, no. And what I can do, I can move and reach the bell and Karen. Get rid of that. So, we pay about,
12,000. Wow, that's a lot.
yeah, that's per person. That's on a population base. And this one, is job-based. Premiums are, at least in 2022, $22,000. And you could say, well, the employer pays part of that, but really the employee pays all of it because that's a benefit package. And so some of it comes in salary, some of it in insurance. Oregon households continue to spend more on healthcare than they do on housing and utilities, spending nearly 22% of their budget on health-related expenses. We spend 5 times as much as other countries do on administrative overhead because of their simplified billing and reimbursement systems. We pay somewhere between 20 to 30% just for administrative overhead with all the insurance companies and billing codes, et cetera. And then, of course, there's the pharmaceutical industry, which prices at what the market will bear. For somebody who needs a liver transplant, but that could be prevented if they got the right hepatitis serum. The liver transplant costs $60,000, so we should price the serum at $60,000. That's the way they think. Then there's the pharmacy benefit managers. And we, I think, know that they are also siphoning off a huge amount of money in a very obscure way. We can't figure out who gets what rebate, but it's driving pharmacies out of business. We've lost 32 pharmacies in 2024 or 23, and 24 it was 15 more, partly because of this PBM problem. And then, of course, yeah, corporatization. Any ideas from the listeners here? How is corporation a problem? Aren't business people more efficient, that they do things in lean manner? What do you think?
They have shareholders. They need to make money for their shareholders. That's their whole purpose.
That's right. Yeah. So you probably know that in 2020, United Health Group subsidiary Optum purchased Eugene, the Oregon Health Clinic in Eugene, And within a year, 32 doctors, or 2 years, 32 doctors had left. And we have no way of really documenting why they left, but we think it's moral injury, being asked to do things that they know are not ethical. And then Portland in 2021, Greenfield Clinic, Corvallis, we're fully aware in 2024. So we talked about cost. How about access? Anybody's got ideas? In addition to cost, what other problems are interfering with access?
Not enough doctors.
Not enough doctors. Anybody else? What if you live in Burns, Oregon?
Lack of rural healthcare providers.
Yeah, lack of rural health and funding for that.
Changing of panels. Provider panel changes,
Provider-
causing people to have to find something different, change their provider.
Yep, yeah. So, what are some of the causes we just talked about? I meant to ask you, what proportion of working adults, this is nationally now, are inadequately insured? 1 out of 5, 2 out of 5, 4?
Looks like almost 3 out of 5.
Yep, yep, okay. And then here's more data. That working age adults skip care now than when the ACA was passed. You can see the increase. And that's obviously because of cost.
Immoral, terrible.
Immoral.
Yeah. Oops.
All right, we talked about cost, access, and our audience here. What about equity? In addition to the other 2 reasons for inequity, what other things make our healthcare system inequitable?
I have my hand raised.
Oh,
Speak up.
oh, there you go. Thanks, Lou.
Look, I work hard for my health care and they take care of me just right. I mean, I have no problems. I have great health insurance, costs me a couple of bucks now and then. And I work hard for that. These other people ought to be working as hard as me and earn their own.
I agree. What do you think about that? Anybody else have a comment? I shouldn't say I agree. Any other views on this?
Yeah, this is Colin. I've got a comment.
Yeah, go ahead.
Okay. Yeah, I'm on driving, so I can't really see the screen. So thanks for helping me out. I've been considering saying to people that are very happy with their insurance that even at their best moment, they're still being swindled. Like they're still overpaying and being underserved. Even if it's the best that they've figured out a way to achieve, it still is a scam.
Yep.
But what if I don't think so, Colin? How do you convince?
Well, then I guess I'm the first person to let you know, and I can list the many ways in which you're being totally scammed.
Okay. We should talk about that.
Yeah.
Yeah.
What about that bum that drinks too much, smokes too much, doesn't take care of his health? Why should I be paying for him or her?
You are already.
You're already paying. Yeah.
Okay, as long as we have EMTALA rules, which who knows, they might be in jeopardy someday, but yeah, we end up taking care of the damaged kidney, eyesight, legs. We do all of those things, dialysis, but we don't do adequate work to prevent those problems.
Listen, more important is that if somebody else is sick, so are you. Guess what? Diseases, problems, etc. are contagious. You don't sit there alone in your good, happy castle unaffected by the world around you, period.
Could everybody hear Isabel's comment?
Yes.
Yeah, sounds argumentative.
Yeah.
I feel like, I don't know, if I had the opinion about people that didn't take care of themselves, the argument that we already paid for them is a little, I mean, like, that's sort of, I guess it's like abstract. It's like, oh, well, I guess maybe I pay for them with tax. People don't really understand that necessarily. So I think that's a good argument, but is there another way to, like, what's the best way to describe why you're still paying for them and the system is way more expensive than it has to be? I don't know. Just like, how would you describe that to them?
Well, I like the trend here is most people are interested in self-interest. So if you realize that the person just prepared your food or harvested it or sitting next to you on the bus or in a public meeting could have tuberculosis, COVID, would you want a little better healthcare to prevent that from happening? Other ways of inequity.
So,
go
So
ahead.
again, this is Susie Beef from the Southeastern Oregon organization that's sponsoring this talk. And
Yeah.
I'd like to go back to the idea of universal health care that, people in our neighborhood do believe that almost everybody believes that people deserve health care. People shouldn't be shut out because of a health issue, but we also believe that we've already got it. Our communities take care of people, our hospitals, our emergency rooms have to take care of people who need care. So I don't understand this question. And we think that people have access already in our areas. Why should we worry about that?
So anybody want to answer Susie?
Well,
Sounds
Susie,
like, go ahead.
there's probably a lot of people, Susie, that you can't know everybody, even if you're in a small town, because we live in a small town in Eastern Oregon, and we don't know what's going on behind everybody's door and the pain and suffering. And when these surveys come out and they ask people, there are a lot of people who aren't getting the care they need. And I know about a son who can't afford it, and his family, they make too much for the subsidies and not enough for the real cost. So they take a chance. And if something bad happens, they're just gonna have to try to go in and then could end up with a whole bunch of medical debt that ends up with their bankruptcy. So I mean, I think there are a lot of people that maybe you don't even know what's going on behind their door.
That sounds reasonable to me. How about skin color, ethnicity? Any problems there with equitable care? On this diagram, you can see the uninsured by race and ethnicity. Top line being Hispanic or when not Latinx. Then next is white, and then black, and then white. So a definite difference.
So what if it was because they just don't have the jobs that give them the health care that they don't put in the work and get the education to get the jobs to give them the health care that they can benefit from, that we benefit from.
That's exactly right. So we should not, what's the answer to that? Anybody? They haven't been working maybe, and so maybe they don't deserve, they haven't earned their care. Any response?
With all due respect to whoever said that I was argumentative, try being black for a day, for just one day. It's not an issue that you don't work. It's not an issue that you don't care. It's that you're not allowed to have the same benefits as everybody else. You simply aren't. Your teacher assumes in kindergarten that you're never going to make it because you're black or Hispanic.
All right.
Very sad, but true.
Also, I would like to add that not only are they uninsured, but the outcomes of the treatment they get are far worse. There's more, there's a higher maternal death rate with Black people and Hispanics than white people.
Yeah,
So there's inequity throughout the system.
there's also inequities just related to income alone. And you can see here, the comparison of, people in several countries, Canada, France, Germany, and UK, even the people of low income have an easier time getting healthcare than the people of high income. So you compare this 15% to this 27%. A little embarrassed. Then we talked about equity and equality. So how are we doing in equality? We're the best healthcare system in the world, aren't
If you're rich,
we? Yeah, temporarily until you pay your bills, your hospital bill. So I think the most reliable indicator is avoidable deaths per 100,000. That's not influenced by other social and economic factors. So in the US, where we have many more avoidable deaths due for a treatable illness. Just one more, look for an outlier somewhere. Compared to 9 other countries, and you can see on the left arrows, higher performing at the top, lower performing, we're bouncing on the bottom there compared to these other countries. Any comment about this slide? Any experience that you've had with any of these countries?
I my dad led a bike trip in Germany quite a few years back, and I ended up having to help out, and one of our people on the tour got hit by another bicyclist and hit her head and ended up needing to go to the hospital. And it when they took care of her and patched her up and made sure it wasn't any brain problem, etc., and when she got ready to leave the hospital, she said, well, here's my Blue Cross insurance from Oregon. And they said, oh, put that away. You're here. We just take care of you. That was the end of that. And she was in the hospital a couple of days and got excellent care and didn't pay a thing.
So thank you, Carolyn. Now I need to check with Susie because she wears 2 hats. She's also keeping this program on track. And so far I've used up all my allotted 15 minutes and we're just halfway through. Partly because we're making this a basically a living room conversation rather than a presentation to the Kiwanis.
So Mike, here's what we should do. I mean, we're demonstrating issues that we encounter in trying to set up the Speakers Bureau, and one of them is going to be speakers who find themselves going over time. What do you think you should do here? Susie Beef is not going to interrupt you, and there's been quite a bit of interaction with the audience. So, if you think speech followed by discussion, we demonstrated the mix them together method. What would you do if you were in a real situation and this happened and you had to finish?
That's a question for the audience or for me?
Well, mostly for you, but
well, first I would say that's a cardinal sin to go over the time that you're allotted. People have other obligations, get back to work after the noon lunch, whatever it is. So it means parsing your slides down far lower than you really want to, because you have this wonderful information to share in 10 minutes.
Well, actually, given the purpose of what we're here for today, maybe we should stop here. We can come back to this set of slides later.
Okay.
Why don't we just stop here and go into the rest of this and then and see if we can achieve our goals for today.
Okay,
So
are
I'm back as Sandra. Next on our agenda, we had hoped that John would have been able to be with us because John Rickards has a story. And it's a story I just heard again recently in a healthcare HCAO committee. The story is volunteer, new to healthcare for all, discovering the importance of the issue, discovering that there is such a thing as HCAO, says, I want to be part of this organization. I'm a good public speaker. I want to give speeches on this subject, and is going to be referred to the Speakers Bureau. We got John before there was a Speakers Bureau. So John got to be on the team that is developing the materials to help speakers. And his perspective has been very helpful, because how can HCAO help people become a speaker? But one thing that John says in his story is that it didn't take him long to realize that even though he was enthusiastic about the issue, he didn't know squat about healthcare finance, about the issues about healthcare for all Oregon, and he needed to learn a lot more about the problems and the potential solutions, and how people could plug into those solutions. And I just met somebody else who's been referred to the speakers team by HCAO office, and that person says, I want to be on this because I am a very good speaker. I will be a good speaker. I want to give speeches on this subject. But he didn't know what an HCAO chapter is, because we are at a situation now, especially after the murder in the New York area of the healthcare executive, where we have a burgeoning amount of enthusiasm for our topic, that people recognizing that there are problems, and we have to figure out how we're going to respond to incorporate, build on, strengthen our movement by incorporating that enthusiasm into a program that really will be effective. I worry about having a volunteer come. I remember when I was brand new, I came and I sat in the legislative committee and got on the HCAO board early, and I was learning like crazy, learning very, very fast. But boy, I didn't know very much at the beginning, and I had an organization that helped the organization that helped me learn. We have to be an organization like that. So that's what John, I think, would have said. And that would lead into then what John and Mike and I planned for the third part of this event today, which is, I've often called this event the fake training. You people here don't need to be trained. You need to help us figure out how to train other people, including these brand new volunteers whose enthusiasm we want to capture, while also making clear that there's a little bit of homework you got to do before we think you should become a speaker for HCAO. Mike, did you get, that thing I just sent you? You want to throw that on the screen somewhere?
Email?
Yeah. It seems appropriate to start this part by talking about our goals and purposes, including the goals we have for the event today and the goals that the team that putting the Speakers Bureau together has evolved for the so-called Speakers Bureau program as a whole. For today, the goal is to get your feedback so we can make this a better program. For the program as a whole, some of you have heard me say my vision is to have a statewide team of at least 100 people who are ready and able to give a speech, a presentation for HCAO. They need to be spread around the state so they can travel places easily. But the goal is to build a large team in support of what I believe in 2027 or 28, probably there will be another ballot measure, whether put forward by the advocates or the opponents of universal publicly funded healthcare. And we need to have a statewide presence, statewide teams, and knowledgeable people statewide who can be part of that, can participate in that activity when we the ballot measure ballot measures aren't final either, but it'll be a big step toward implementing publicly funded universal health care in the state of Oregon. Therefore, a goal for the whole Speakers Bureau program that we have talked about a lot is that we want to train people and have events that are persuasive, not simply informative. I used to teach public speaking, and there's a big difference between a persuasive speech and an informative speech. One of the things I wrote down is how do you want people to be when they leave the presentation? You want people to say, because I attended this HCAO event, I now know this is my kind of movement. I care about this. I really want it to succeed. We do not want people to walk away saying, okay, now I know more of what this is about. That's not enough. They have to know more what it's about in order to develop that commitment, but that's not enough. And one of the things I'd like to see us have is an assessment after presentations, because you can measure how much people's support for publicly funded universal health care has changed as a result of what they just saw. That makes numbers. I love numbers. But if the whole program is about being persuasive, building support, not simply being informative. It will have to be informative in order to do that. Not simply being entertainment. Some of the organizations who sponsor us are going to want an after lunch entertainer, but it probably will have to include being entertaining as well. If we want it to be persuasive, how do we do that? Okay, audience feedback. Here we are, experts. How do we design a program so that the presentations will be persuasive, not just informative, not just entertainment? What do our presenters have to do? What does the program have to do to help us achieve that goal? I didn't give you a chance to disagree about the goal, by the way. You're not allowed to disagree. The persuasiveness is we're stuck with it. But how do we achieve that? You all have a lot of experience. You know what works and doesn't. Some things that work and some things that don't.
Can I
Go ahead, Lou.
do that?
Go ahead, Lou. How do we do that?
Well, that's what I've been trying to figure out. And one of the obstacles is having at my fingertips all the jobs that are available, every niche. A lot of people that want to get involved, some want to dive right in, right? Others need a follow-up. Others just want to do a little bit once a week. But in my mind, I cannot come up with those, oh, well, what are you interested in? Oh, well, here's what you can do. That's what I'm dealing with.
Okay. So we
I
need
think
a
that's
good
being
response to
worked on.
volunteers.
I think I've heard something about the 30 things you can do, or I'm just trying to remember who it is that's developing, but I do think that there are some HCAO folks that are working on this right now, Lou. So,
Why aren't I talking?
Tony, do you have that answer?
Well, Lou, we took your email and we put it to work, and we put one of our great liaisons that's had some tremendous input on organizing and thoughts on that. And we've taken piece of that, and the idea is that is in motion. And I think this is something kind of we've talked about it seems like the last week almost, last 2 weeks, of these specific spaces where volunteers and people want to be engaged. And I think the thing is that people can engage at multiple different levels. So I won't go too far into that because I think we got a lot of work here to talk about today. But I'd love to circle back with you because Colin and a couple of the new members on the legislative committee are really putting together an introduction to HCO and giving some grounding and some scaffolding and some infrastructure for themselves to fill a very weedy topic that many of us have been on this call working on for decades. and don't have all the answers. I don't have all the answers. I've been working at this. I have an MPH and been in healthcare for 25 years. So I can't, we can't expect everybody, but hopefully it'll get them some support on that.
Okay, I'm going to intervene here, Kate. I hope you'll forgive me. The question for today for this group is not what can HCAO do? It's what can the Speakers Bureau do? So I want you to think not about what do you want HCAO to do so speakers can talk about it. There are other we have to think about that. But that should be done in a different place. Maybe in Tony's email, for example, or the HCAO, the board meetings. And I've been there. They're right. It is in process. But what can those of us who are trying to prepare a team of 100 speakers statewide, what can we give them, teach them, push them for, so that they will be able to deliver presentations that are highly persuasive? What have you seen that works? What's persuaded you? What have you done that you think has persuaded the audience? What doesn't work? Got anything to I mean, we have some answers to this too, but I don't want to prejudice you by telling you our answers.
Mary Lou.
Mary Lou. Mary Lou.
Okay, Mary Lou. Sandra, you said you taught speech and persuasive speaking. I think you need, yes, what we're doing today is the content, but I think the thing people remember isn't so much content as how they felt listening to the person and getting that. Yeah. And so, but I think there should be a session. I mean, I actually think if people really want to do training and want to give these speeches, we really do need to have a Speech Academy 101 or something like that, that is taught by someone like you, or I keep thinking about Toastmasters, or people that really practice the art of giving speeches and know the difference between what's an informational versus a persuasive, and how do you do that? And I mean, I gave speeches a lot years ago and took speech classes, but I have to kind of dredge up again how to do that. So I could use some refresher, and there's maybe some people who just haven't really done it, so I think that's one thing. And I think that, but I think you're right. I mean, we really do have to have people kind of who learn how to be entertaining and how to, persuade. I think just a kind of a boring informational speech isn't going to do it. And, and if people really want to give them, I think they're going to have to be willing to go through this training kind of thing that you guys, and I think you'd be a great one since you've done this, Sandra.
Yeah. Oh, Lou.
Yeah. I understand what you're saying, but I'm also looking at the time that we have to move, 4 million, well, at least 2 million.
1 million.
Anyway, the time that we have to do that. I think that the audience has within them the answer to the questions that they're looking for. I think they've been motivated to listen to you. They've been motivated to the more that you can ask them questions and get them responding, the more vested they are in the program and what you're telling them. So, if I'm doing a one-on-one, if I'm doing a small group, I ask them how they're doing with their health care. What are their problems with the health care? And they start to tell me, and other people hear that and they relate to that. I think people want to move on this. The thing is, how can we channel them, to a good resolution here, a good movement. So anyway, just my input.
There is a standard answer framework that I think puts together what people have already said and may relate to what Tony, Colin, and Kate and Mary Lou are looking to add to this discussion. But the standard answer is the one we've talked about constantly in HCAO, which is it's about the relationship. When we talk about
Yeah.
reaching out to our legislators, build a relationship. When we talk about fundraising, it's build a relationship. And what we want to do in these presentations is establish as much of a personal relationship as you can during the time that you have to be with that audience. This is not a group you're necessarily going to be able to follow up with like all the time, like we do with our legislators and our donors. But one does that by being a person and treating the audience like people.
Exactly.
It's where when one does enough revelation about self to show that you are a person. That's where a personal story can come in. And it doesn't have to be a story of healthcare disaster. It can be it can be the story of why you love HCAO. But for the speaker, the presenter, to be a human being, but also in treating the audience as human beings, that means asking for their input, ask for their experience. Ask and then take it seriously. Don't just say, oh, well, that's not right because blah, blah, blah. To take it seriously. And also to treat, that's the bottom line though. And what that means is those assumptions, those strategies can be built into the planning for a presentation. Mike was demonstrating what we're trying to build into the slide deck, which is here is an opportunity for audience engagement. Here is the question. Here's several versions of the question you can ask the audience at this time. Here are several versions of the kinds of answers you would get back from the audience and what to do about that. This is not on the slides. This is probably going to be in the speaker notes. And some of it is in that document called Guidelines, which you got, which was our first attempt to try to articulate what this approach is. But it means you are no longer the sage on the stage. You are no longer a speaker. I hate to call this a speaker's bureau. You are a presenter who is going out there to have a conversation. Colin had a name for something he just did. Are you still there, Colin? We want to steal your name and call this Community Conversations.
I
But to
will allow
build-
you to steal the name.
Okay, you build a relationship through your personal engagement and for building audience engagement. And that's why, if a person goes away from the presentation and said, well, when they asked about so-and-so and I told my story, they didn't give me the same standard response everybody else does. They listened to me and took me seriously. That's what we think is the foundation for being persuasive rather than just informative. It's all about the relationships. Tony, you're first on the list, then Colin, Kate, and Mary Lou.
Well, first off, it's great to be with all of you and this body of work. I think this is really incredible, and Sarah is setting the stage. I think just a big thank you, a bit of gratitude to everybody involved in this endeavor, because I think one thing that we've all been interested in is getting into more communities, getting in front of more people, getting our message out in spaces and places that we haven't been, right? The interest is to broaden our message and the understanding of people. And I'm in complete alignment with Lou that people know the problem and we have the solution. What I would say is that, thinking I've given many talks across the state, and whether that's at a Rotary Club, schools, hospitals, ground rounds, all of that. And I think just kind of the way that you guys have set this up is that this is skill building. What we want to do is empower individuals to feel safe to go do this and be able to be somebody that can start to answer all the questions. I do worry about we're not going to be entirely complete. Even people that have been speaking forever are, again, like I mentioned earlier, not going to have all the answers, right? And be this. But I think giving the skills and the messaging is really what we want to give to them. I do think that, Lou, you're onto something, and I agree with you that some of those can be in smaller settings or bigger settings, and we shouldn't risk the enemy of perfect for good, in this endeavor is one thing I would state, that we want to give people the slides. We want to give them again, that scaffolding and let them go to work, right? We do want to stay on message and branding, right? That's something I think we need to maintain. And I think you guys have done a good job with that, those guidelines. Your question, Sandra, is, who are resources? And I think, Mike has a really wonderful connection to One Pair as far as speakers, and PNHP, and Ed Weisbart has done a number of really phenomenal presentations. Mike and I went to this in 2019, where he just gave us some tips on how to be a good speaker. What are the do's and don'ts of making a PowerPoint? I do wonder if that might be an individual, and I'm sure he would. I know he's reached out for that before in this space. Anyway, I've talked too long. Again, really great deal of gratitude for all this work and phenomenal job.
Colin.
Hello, can you hear me?
Mhm.
Yep. Thanks. This is great. I just wanted to echo Tony as well, about not letting perfect being the enemy of good. I think if we are trying to, educate ourselves and new volunteers about all of the nuances of like healthcare financing, we'll be ready to speak in 2030, there's no way to learn, or I've given up on even assuming that I could ever possibly learn it all, but I want to know enough in order to direct Oregonians with questions to the right people who can find an answer. So I did this last weekend, I did 2 events in Baker City and Enterprise, the Universal Healthcare Community Conversations, and they were not perfect. They were super fun. I think they were overall great. And Kate was able to come to the Thursday one. But I, between Thursday and Friday, made some adjustments to my slides. I'm thinking about it differently for the next one. The one thing that I think was cool about those was having them be informal. And so sort of hitting home at the beginning of my particular presentation that it was an informal event, and that questions and conversations during the slideshow was welcome by me. And in Baker City, that was well received. Lots of conversation during the slideshow. At Enterprise, they kind of listened and we talked at the end, but I liked having that difference. So thanks for listening.
Great. Great work.
Thanks, Colin.
Yeah, we have Simon in the queue here. At some point, he's been holding his hand up for a while.
Simon, where's Simon?
I'm here.
Is he in your room?
Listen, I'm. Do you see my hand? I'm kind of beneath the.
No. I don't see you. Just talk, Simon.
I'll just talk. No, I feel like one of the most important things that I would care about the most in this would be being prepared to understand who I'm talking to, know the audience I'm talking to, and be prepared for that. Because, if I'm going out and speaking, going and talking to a group of university students versus going and talking to a group of people who live in a small town in Eastern Oregon, the environment is going to be very different. So basically being provided with the preparation to be able to know the audience I'm going to go and talk to, and based on that information, be prepared as much as possible to be able to make that personal connection, like you said, Sandra, and be prepared for those harder, perhaps more confrontational questions like the ones we threw out there as examples. I feel like knowing the audience, the value of what I'd really like would from something like this would being given the knowledge and preparation to evaluate who I'm going to talk to so that I can most effectively make that personal connection and make the presentation persuasive, depending on who I'm talking to, right? Because, I think what different groups are going to find persuasive, and the ways that we make those personal connections are potentially going to be quite different from group to group.
I'd like to interrupt the flow here a bit, because what Simon said is important, and I think we should address it now instead of waiting until it comes up later in the list of things I wanted to talk with you about. But we have, you saw what the slides that Mike was able to give. There are other slides that Mike left out. knowing that he was preparing for a moderately conservative organization, he left out all the slides about how bad corporations are and how good unions are. The other thing you saw in that was when Susie came in and said, we know how to take care of our own. I'm thinking that in terms of preparing people to be speakers, it would be helpful to have a list of the ways in which audiences might differ and how you can find out where your audience stands. The main way you need to find out is by asking the person who invited you, the person who's your sponsor. But people different in what is their political persuasion, what is their prior knowledge, what is their social class, what is their race, what is the region they live in. All these things are things you want to know about your audience. Maybe the most important thing is their political grounding and how much knowledge they have. And then you have to change the slides and adapt your whole presentation. Just start by aiming at what you learn and be ready to change it on your feet if it turns out that what you thought wasn't correct. But what are you going to change? You might leave out some slides. The ones we got a real education from Warren George on how not to talk about corporations and corporate executives to an audience that has corporations and corporate people and corporate executives in it. There's some stuff you have to leave out. But you also have to, speakers need to learn about language. So we're thinking maybe we could provide for speakers some sense of what the language should be. There are places where you don't want to say single payer. There are other places where you do. And if we can help our speakers adapt to the audience that they have in front of them, maybe by giving them some of that information. The thing that I did when Susie interrupted and said, we know how to take care of our own. Don't talk to us about. There are people who don't have health care. We want everybody to have health care, and we're already doing it. One good thing to do is if you're talking with an audience whose views are not the same as your own, find out something you can really praise and identify with and support in what their views are. When Lou says, Lou, I love your phrase, I'm going to steal it in every way I can. The audience has the answers within them. We have to reach to find out what is it within them that moves them to support publicly funded universal health care. And we have a lot of good clues about that. We can learn that from a lot of different sources. If we can't, we start the presentation with finding out what they think they're doing right, finding out what they like about the way their community supports people in need. But that thing, finding out what not to say, and then figuring out what to say to create that bond with the community. Those are the two prongs of, I think, of a response to that really important point that Colin brought up. And if we didn't get to it now, we might not ever get to it. But it's become, we're trying to build it into the training, and don't let the perfect be the enemy of the good. I'd like us to be a little better on that before we send this out. Anyhow, I wanted to make sure that got in there. Kate, you are next on the queue.
Yeah, a couple thoughts. I think we could talk use some of the motivational interviewing strategies, and there's a difference between listening and hearing. Talking about that might be useful. And in the beginning, and Colin did this in his recent engagement with an audience, to ask people, what do they expect to get from being here? What do they want to learn from being here? And I think in the case in Baker, for example, there were people with differing needs and thoughts, and they were very conversive in bringing those up. It worked very well. So I think that's a really good first question. What do you expect to get from this? And I think also when introducing oneself, or someone is introducing you, to really kind of get the message forth that I'm really invested in this. I think this is really important, and be really enthusiastic. And the time is now. This is urgent. The time is now, because this is coming out soon. We need to really engage people and to give that kind of message that, this is urgent. We want to move forward. So that's all.
Thanks, everybody. I'm making a lot of notes here.
Okay. A couple of things. I think that like service groups, like Rotary, Kiwanis, Lions, all of those
Yes.
groups. Okay. I think my first husband was a banker. And so every branch of US Bank, somebody gets assigned to be a Kiwanis, a Rotary, a Lion. They want to cover and be in all those service organizations. His major thing was they were so damn boring to go to these meetings and have a cold egg at 6:30 in the morning. And they were always looking for, somebody would come and kind of jazz it up a little bit or make it so that they weren't so damn bored. And, there's probably real avid Kiwanis and Lions and all those people, but I think there's a bunch of them that are just kind of sent there by their business to make connections, et cetera. So I think you have to kind of think about, who are these people and how can you, like you say, engage them quickly, find something, make them laugh a little, kind of make fun of yourself a little bit sometimes, or, kind of connect with them that way. Also know how long do you have? I think that, when Mike was all of a sudden after 15 minutes, almost out of time, I think there also needs to be almost kind of a minimal amount of time that maybe you need to talk with who you're going to be working with, because there are things, if you're going to be engaging people, talking and trying to get them information and trying to do all this, you can't do it in 15 minutes, I don't think. Maybe there's something different you can do, but that's just my own personal thing. And I think that you're right about trying to get to know what it is they kind of expect of you, but that can go on a long time. So you got to have, I think, techniques to kind of say, thanks, let's get going. And the other thing is that from a couple of presentations I've done, I think about the problem, sometimes we focus way too much on the problem, because I think if people kind of, you get a few stories or a few something out there and say, we could go on for hours about the problems. And I hear you, and we've all got our stories and they're really important. But the fact is, we want you to know there's a solution. And this is the solution, and really spend our time talking about that this is possible and that it's, not a dream. It really can be done in Oregon. And this is what this organization, and if they want to get more involved in it, here we are, blah, 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 something like that. But I think that, I do think that most people will agree there's some problem out there. But I don't think there's a solution. That's all.
I just made a really important note about service clubs. We know that the Faith Caucus has shared with us some slides which establish common Christian values by quoting Bible verses. Well, what the hell? We have common values with Rotary. We have common values with Kiwanis. They all have mission statements. They have value statements. All we have to do is look them up and quote them back to them in our presentation, and we've already established some of that common ground that I think is one of the building blocks toward this is my kind of movement.
Yep.
But it means you've got to know what your organization is and look up the stuff. And I think if you're doing something like Susie's organization, which was what? Business and agriculture people in southeastern Oregon, you got to scrounge around a little bit to find out more values of that seem to be expressed by people in that area. But that's the start, and that relates with what you ended with, Mary Lou, which is I started saying let's have a speakers bureau materials. I thought problem solution. That's what we do. We start with what's wrong with it, and we start with no. At the membership meeting in Corvallis last year for HCAO, we heard people talk about values. I went back and looked at stuff that I had collected about talking about values. We're structuring this to try to get our people to start with values, to establish common ground with values, to establish common ground with loose as of what people already have in their hearts about this. From there, you can put as much or as little time as you want on the problems. Then, and after that, emphasize the solutions. But as they said in Corvallis, and I've said in other books like Weston's book, Drew Weston's book and stuff like that, progressive Democrats talk too much about the problems. And that is causing people to say, these people are just so gloomy. I want to talk about be great again. We don't have to start from that emotional plane that everything's going to hell in a handbasket and we're the only ones who can save you. Somebody we know who's about to get inaugurated says, everything's going to hell in a handbasket and I'm the only one who can save you. That's not going to be our message. Our message is we share a lot and we can work together to make very good things happen. Thank you, Mary Lou. I pulled that right out of what you said. I hope you recognize your authorship in there.
Thank you.
Is somebody in the at Mike's house wanting to talk? There's a hand up there.
Yeah, that's me. Just a nuance on finding out what your audience expects is to go ahead and ask, like you said, what is it you would most want to come away from this meeting with, and have somebody write down those items. I want to know how much it's going to cost me as a farmer here, and I've never been able to afford health insurance. And then at the end, you go through that list, 5 or 6 things they really want to be sure you talked about. And did we answer that question? And if not, here's my, I will get in touch with you, give me your phone number, so on.
Yes, Mike brought this principle to us very early in our work. The first thing we should do is ask the audience what they want to get from the presentation, and then write it down and refer back to it. Kate.
And my microphone.
There you go. Here we go.
Well, I really like this idea, though, of changing our, what we call ourselves to just universal healthcare community conversations, because it really does invite engagement. I think it's an important change. And I just want to mention, I did see the new work on volunteer. There's a handout that looks wonderful. It's so much clearer than what we had before, and we have somebody in the office, and I'm working with them and Trina to make sure volunteers get tied in right away. They get an orientation perhaps, and to really have a real conversation about it, what they really can do, and have them be plugged in, which has been a weakness before, I think.
Yep, HCAO moves forward all the time. Colin.
Yeah, I just wanted to comment on that name. I think it's a clear name, Universal Healthcare Community Conversation, and still with the last minute sort of work, I basically had a month lead time before the 2 events this last weekend, and it made it into like a local Baker paper, and it went through some email channels in the Wallowa County. 15 people showed up at each event, and there were no outwardly conservative or libertarian people. It was all people who more or less already agreed with me. So there was no even opportunity for discussion that was challenging. So something to think about.
Okay, I will go back to my outline. There are just a few things left on here on which we want your opinion and maybe your input. Let's just follow up with Colin. What audiences are we seeking? We are not going to try to speak to the outwardly conservative and libertarian. We're not going to try to prepare speakers to do that. We have a serious problem in Oregon with the middle. We have a bunch of Democrats who don't yet realize how strongly they support our movement. We have moderate Republicans who we think we could peel off. The best we could hope for with the far right is to make them oppose us less, which I think is a worthwhile goal in contacting a Republican state legislator, but I don't think it's a worthwhile goal in taking one of our speaker trainees out and putting him in front of an audience of people like that. So our goal is, we're not even aiming at how do you persuade them, but we have to aim at how to persuade the middle, because we are accustomed to talking to people just like us. And most of the way we've designed our events is to rally them up by getting them all emotional and angry so they will give more money to HCAO. We have to learn, there are places we do that. We keep doing that. We have to reach out to people who are going to respond to a different kind of message. Thank you, Colin, for giving that opportunity. There are 3 more things I want to put before you. Things we can teach our trainees and stress in what they're doing. I think I want to call, I'm getting ready to dump the whole name Speakers Bureau. Maybe call it, I would like to call it Conversation Ninjas, but I'm sure I'll be overruled on that. But we're going to change that name. I've always been uncomfortable with the idea that we had speakers. We've talked about presenters. I like the idea more that what we're trying to do is create a statewide team of 100 conversation leaders or conversation ninjas, if Michael let me do it. Point one, I want to teach everybody, never read anything. Never read your slides. Never read your notes. Never memorize your speech so Sandra won't ding you for reading it. Why? We're not telling you not to read it because there's something bad about reading it. We're telling the trainees not to read anything because every time you're looking at something to read it, you're missing an opportunity to watch your audience and see what they're doing. See what they're feeling. See if they're tightening up. See if they're opening up. Are they smiling? You can't keep your eye on the audience if you got your eye on some text. And this is where I will let the perfect be the enemy of the good, where I really want them to come out of their HCAO ninja training to know that they are never going to read anything. The one exception I would make is if you have a brilliant closing sentence, you can write it down and read it, because sometimes it's hard to say goodbye. And that closing sentence or two sentences might be one you want to have in front of you for it. So that would be never read. The second thing is we have talked about how the training must include practice. Has anybody here ever done Toastmasters? Toastmasters is all about practice, practice, practice. There are many reasons why you practice your speech. One is so you don't have to read anything. And I believe in practicing by talking to a tree. I would talk to one of my chime clocks here. But practice, practice, practice so you don't have to read anything, and so you know how long it is, and you're not gonna have a speech that something coming from you that's too long or too short. And the third of those keys for the training model, we didn't get to it because we cut Mike's speech off early, but here, the perfect also needs to be the enemy of the good. End with action. Every HCAO event should end with the conversation ninja telling people how to be involved and making the strongest possible case for why people ought to do it. That may be different things for different audiences. Whether one talks about the importance of a financial contribution, or one hopes that we will get engaged volunteers who will become super duper volunteers during the next couple of years, depends on who the audience is. But to always end with action, never end with, so there you have it. Now you know what the governing board is doing. There has to be a clearly planned action section. We got slides for that. And that should have the biggest emotional weight of the event. I think we've talked a lot about, I've given you a lot of things to ask for and gotten a lot back. Do you want to send anything back to our team about these items? Will you let me be be the enemy of the good in the reading your slides thing?
Quick question about technical something, Sandra. If I could ask. Okay, so every presentation I ever go to, the damn slides, the technical part never seems to work. Everybody kind of applauds, and it kind of like whatever, you waste 5 or so minutes trying to kind of get whatever going. And I think Mike is probably one of the people who's the most technical savvy people that I know, and he's always able to do these. And so, but today, so what kind of capacity do you need on your computer? Or do you need, I need some technical stuff about, I don't want to be saying my slide isn't coming up or what is happening. And so I don't know if there's anybody who can help us with some of that technical capacity, or what do I ask for at some place? Do you have X, Y, or Z that I can plug into?
Yeah. 3 things. One is making sure you have the equipment you need at the place. And what we're recommending is always take your own in the trunk of your car. If their equipment doesn't work, you have your own in the car, and you can get it, and you can put it out and use it. Second is always be prepared to do the whole thing with no tech.
Mhm.
Do not see if you're going to read your slides, you got to be able to see the slides. So you got to be prepared to do the whole thing, lead the whole conversation, keep it structured, keep it orderly without having any technology at all. And the third thing is we're trying to figure out how Mike can set up some tech training to help our people have the skills to deal with the kinds of snafus and stuff that they might encounter. I don't know if that's going to be enough. I'm inclined to think that given our emphasis on building the relationship and the persuasive speaking and being person to person, the number 2 is the most important, which is be prepared to just talk.
Mhm.
And that doesn't mean to just sit there and let the conversation go wild. Do you remember at the beginning of our time together when I said, wait a minute, that's what HCAO needs to do today? We need to talk about what we can do in our training for our, I got to call them conversation ninjas, but you got to be prepared to interrupt what other people are doing and move it toward the structure that you have set up for how you want that thing to go. But that you can do that without slides. I mean, I'm doing all this without slides. I got a little list of things in front of me, but anybody can do that. It's not technology. Technology gave us the option for people to read their slides, which was just as bad as the internet turning out to be a great way to get porn. You know, technology allows bad things to happen, but we can also go back to our humanness and maybe not even need so much of it. You know how people sometimes praise speakers and they say, talk for 1 hour without even referring to notes. You know, people sometimes think that's a good thing. So we're worried about this, Kate, Mary Lou. We've worried about this technology thing. I don't think we have the answer yet, but
Okay. Scares me. I'd rather just have my stuff, notes, know what I'm going to say or how I can pivot, something to keep me on track. But I personally, don't think the technology is
well, you do, and then you got your notes and you write all over it and you cross out the things you're not going to do that day. And sometimes it's a lot easier to have no technology better than paper and pen. Technology. Now, see, Valdez might say, Sandra, this is a generational thing. People who are younger generations really love the technology or something like that. And I don't know. Maybe it is. Maybe Mary Lou, you and I are an older generation who are less committed to technology.
I see Tony and Colin and then me.
Okay, go for it, Tony.
Yeah, maybe some tips, Mary Lou, is I think you answered your own question. It's going to go wrong. You're going to have hiccups. That's why it happens every time, is what I would just, kidding. So I think, I think the points outlined are excellent in that you have backups, right? So you have kind of if it's really necessary, print out your slides, have it on a USB, have it on a Google Drive. I've had to do it in 4 different ways sometimes. So I think just maybe that is in this toolkit that we're giving folks is let them roll with the punches, roll with the hiccups, and plan accordingly. And that goes with practicing what you have to say in advance, multiple times as Sandra has put forward. I wasn't going to do the Sandra, but I am going to push back. And here's why.
Good.
I agree with you. Technology has led to some bad habits. I think this is that area where we want to get more people involved, and some are going to feel comfortable and some aren't going to feel comfortable with doing a presentation without slides. And I would think that, I think them moving in that direction, but before we let them fly or let them go speak our gospel, I think it's fine if they have a set of slides and they're going through it, right? I think if they're getting their message and they're working through those things and they work towards that, I think that that's excellent. But I just worry about us setting barriers in advance, So I maybe I'm hearing you wrong. Maybe you're saying that, we can get them and we ideally want them to do that. We want to motivate that. But I also wouldn't prohibit folks And I think there is a little generational stuff, you know. So I think, you know, some people are just, that's how they've kind of trained in doing this. Um, you know, I try, yeah, and when I'm teaching folks as far as doing presentations and some of my residents or my students, you know, kind of moving towards that. But I just caution us a little bit of not saying you can't join in this effort by working through that and meeting people where they're at, right? I think that's where I would try and find our
Well,
place with it.
Tony, you cannot suggest that a team that has spent 10 months building an enormous slide collection and writing about how to use it is going to prohibit anybody from using it. Prohibition is not one of our words, although I dearly want to prohibit reading.
Yeah, no, and I get you. And the intention is good. I just think that if this is the group, I think they can do it. But we're going to engage more people, and they may not be as well versed in the weeds of what we're asking and that messaging. And I think learning how then storytelling, engaging the audience, and making those connections, that's the point I think that is the focal point. Yeah.
Colin?
Yeah, thanks. Just speaking, I guess, speaking about reading the slides or and also in the inevitable event of like a problem with the presentation, I think it's important and a good idea to try to rely on trustworthy places, trustworthy like event host spaces. Like the two places this last weekend were the Churchill School in Baker and then Hearts for Health clinic in Wallowa County. And in 2025, I just assume that most places know how to do a presentation, right? And that reliance worked out at both of these places. They do community events. And so there were humans at both places to sort of like help me through. The biggest, you know, as far as technological hurdle on my end was making sure I had the right dongle to plug into my Macintosh laptop, and then a HDMI cable from that dongle to the projector screen, right? So two kind of things, which is easier for me than I really am not going to buy a projector. I don't think expecting 100 people that are traveling around the state to have their own projector system seems challenging. And if it comes to like, should we speak at the Elks Club or the Kiwanis Club? Well, if the Kiwanis like can answer questions about their projector, let's go to the Kiwanis, you know, that kind of perspective. And then
Good
Mary Lou
point.
on like the other, yeah, I mean, like people that we shouldn't have to, we're not reinventing the wheel. People know how to do presentations. And
No,
then the
I
other
understand.
thing on that same
Can I just say something back to that?
Can I finish my train of?
Sure, sure.
Sure, yeah. No, you go.
Me? I just wanted to say back to that,
Oh,
that it was the Mike thing. Mike is the most technically savvy guy, but it was driving me crazy that I'm sitting here waiting for some frickin' slide to come up. And so I'm kind of going,
Totally.
if Mike has that trouble, how am I going to be at the Kiwanis that has breakfast at the Pancake House? You know,
Right.
so anyway, it's just that kind of thing that I personally hate going to presentations where there's a slide, and I'm sorry, Tony, but every doctor I know does it, where they put it up, it's got the dot points, and they read them to me, or they put data up that's so small that I can't see it. And so I just personally, you know, a slide is great, but I want to see it kind of quickly. I kind of like slides that have pictures of things because then somebody isn't reading their dot points to me. But anyway, that's just my own personal. APHA has driven me crazy for years for that. That's all.
Yeah. One other idea that I used over the weekend and that I'll use with my presentations going forward is that I had a ton of slides. I had 70 slides, which I know probably somebody on this call is clutching their pearls maybe about having so many slides, but each slide wasn't actually anything really to read for the audience. Like there were lots of images and a few charts and a few statements, but it's really to like prompt my brain. So in the event that like none of the projection screens worked, I could just go through my slides, and me looking at my own slides without anybody else, able to look at them, I still would have been able to do my spiel and get the information that I wanted across. So that's a suggestion.
The number of slides can be a bugaboo. I mean, there are presentations where there are very few slides, like 8 slides, and there's a lot of talking going on while those slides are on the screen. There are also presentations where a slide goes slide, 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 and that each one is like 3 seconds or 4 seconds, but they're different in ways that make a point. If you're doing some of those slide things, you'll have a larger number of slides, and I don't think we should judge on the number of slides.
So I see Kate, and I have my hand up after hers.
You're after Kate? Okay, go for it, Kate.
We have a lot of great handouts. We have one that's problem solution, where the problem's described and our progress is on the other side. We have also a map of the time frames, and we have the cost of healthcare handouts. I mean, if you arm yourself with a few of those and your slides don't work, you got something to give people to take if they want them. We've got the little Imagine cards that list, Imagine, no deductibles, no copays, to kind of use to engage people. And I certainly feel better just knowing I could go there and the slides don't work. I had a really awful experience with slides at the university, by the way. So made me think I want to be prepared to do it without a slide anyway. And, a lot of our groups are going to be smaller. And I just wanted the chance my part of doing this with mobilization is really finding the venues to do this and doing the marketing. And we are moving forward with that. I'm really excited to get some people on board that know how to use, say, John Reichert's list of places, and email people are willing to do that, and call people that are members of organizations, for example. And we're really moving forward now on that, and I'm excited about that because, and we're going to do something in Bend, our first one in Bend in April, and now we have a new chairperson or new chapter chairperson, and he is well versed in marketing, so I'm really excited. So I think we're moving forward with more people that are going to help with those kind of things, because that was always my worry. Okay, we're going to have all these slides, how are we going to get people to show up in Bend, Oregon, for example? So I think we're getting a little more expertise that are ready to help us to do that. So I'm excited about that.
I am too. That's really important.
We also have 2 grants that are going to be out there just asking for money to help do just that as well. So, which we're hopeful.
Mike, I believe you're on now.
Yeah, so a couple of things. One is, I would not go anywhere without my camera, my projector, and my own computer. But if that's not possible, and I agree with Colin's idea, if you trust the place, I think the only way you can really trust it is to test it before the event. If you can do that a day ahead of time. There's always going to be something. This one that happened today with the slides is the first time it's ever happened, that particular problem. But there's always something that does happen. So I agree with having your talk ready to go without any slides. But also at some point, Sandra, I wanted to allow people to navigate Google Drive to find these slides, and also to make sure everybody knows that there are many other slides in this. I'm calling it a library. You just saw maybe, 10 slides, and there's essentially about 30 or so for a standard 30-minute talk. But when you go beyond those, there's another 100 slides that may be specific for your audience. And so you can go shopping among those. And then outside of that 100, there's a separate link to slides for faith-based groups and unions. So at some point, I would think to take just a little bit of a tour through the Google Drive to get there, and then a tour of those slides so you can see what there's to choose from.
We've got to add that we are having fun making and editing and updating and changing slides. And I don't think that fun is going to go away. So the slides are going to improve a lot constantly.
So send that Google Drive to us already?
Yeah, you've got it. It's, it's a different one. Yeah, we'll have to figure that out, Lou. We'll put it somewhere where you can get it.
I can get it on Google if I don't.
Mike sent you a slide deck that includes a bunch. That's a good place to start.
Yeah, and those are current and we will be updating them. So we want to make sure you can navigate to them through Google Drive, just to be sure you're seeing the most recent one. So
if you're getting ready to do a talk and you want to make sure you have the most up-to-date version of the slides, email Mike or me and we'll send you a link, because they change constantly, and we find, they're not perfect, but they're getting better. Who we got up here? Tony.
Thanks, Sandra. Hey, sorry, I think my internet's getting really unstable, so I went off video. And if you guys can hear me, okay?
Yes.
Yeah.
Yeah, one cool question. So I guess this just goes back to my comment earlier. Who are our speakers now? And as far as our expansion of those speakers, kind of our thought on that. I know that we're thinking probably the majority on this call. And kind of my comments as far as, I'm not saying we read from the slides. That's not what I'm promoting. I'm just saying that as far as including folks, I just worry about setting those. So that leads just kind of this question of engaging folks to be participatory in this effort. And that's what I was reflecting upon. I agree with you, Mary Lou. It's not preferable to be reading straight from the slides, and the density of that actually is what Ed Weisbart had done a lot of good instruction on. So I'll just call him out again, that I think that maybe Mike, we could rustle up some of that past work that we've seen with PNHP to kind of support people and giving really an engaging conversation on a presentation. I think he does that really well. So just kind of back to that question, is it kind of the group in front of us? And then as we onboard people, where do we think that's going to come from?
The new speakers?
Yeah.
The issue of who are our speakers is kind of interesting, because we already have a bunch of really good speakers, and they should keep doing what they're doing. Maybe they'll learn something from interacting with others and from interacting with us in these kinds of things, but I have no idea who counts as an HCAO presenter. As for the new ones, I've got to get to know them. I just met a guy who says, I'm an excellent speaker. I would be a wonderful speaker for HCAO. And another person who I think would be an excellent speaker for HCAO and refuses to touch it with a 10-foot pole. Some people are new to it. Some people have a lot of comfort making speeches. Some people's knowledge about HCAO or not about HCAO varies all over the map. One of the things I keep saying in our development team is I don't want to be the speaker police. And I'm not comfortable in the role of having to tell people you can do this or you can't do that. I'm not comfortable in the role of saying you can't call yourself an HCAO speaker unless you do such and such and such. I think that may come. I think I might be wrong. I don't know. There's certainly a sense that we have had in the past, people speaking in the name of HCAO, people writing in the name of HCAO, people sending public testimony to legislative bodies with the HCAO logo all over it, where the stuff in it is not exactly correct and may sometimes be misleading, like saying they think a non-single payer system might be better than a single payer system, for example, and having the HCAO logo on their thing when they're saying it. So I don't have an answer to that. I would please think about that. Should there be some kind of...
Well, Sandra, I was just curious. I don't know, Mike, was that you drawing up that list on that Excel file?
Yeah.
Do you mind sharing that again? I'd just be curious to take a look at that.
I'm going to share it, and I hope the people that you see are okay with this. These are people who are here now for the most part, and they all get A's. And then these are others largely from the Mid-Valley, but that we have not asked yet. We don't know how willing any of these are, but we think they could be.
So this is kind of where I'm just curious of next process and next steps. I think, again, the infrastructure you guys have done, but dividing and conquering, and having that list of groups that we want to get out to and reach out to those. Yeah, I'd love to see that. I'd love to let's hit the ground. Let's get out and see. Let's engage those people, and then get those other folks that want to join in on this, and let's start assigning and thinking where we can get in the doors.
Yeah. Yeah, we have a large list of potential audiences. Endless list that John Rickard has put together.
And, with Kate and the chapters and the mobilization committee really getting engaged in this, this is going to be great.
Kate's got her hand up.
Kate. Yeah, Kate, what do you got to say?
Yeah, I think we should remember that a really great use for these slides is educating chapter chairs, volunteers, chapter members, because it will be really helpful for them to have some of that information at their fingertips. And, many people are still doing house parties or doing, smaller venues, coffee shops. And so even if they don't use the slides, if they've got that information, and maybe part of the training is just learning how to, lead discussions. So I think they've got a lot of uses that will help people be better when they're doing smaller venues like we're doing already.
I cut it out earlier, but as we put together the slide deck and stuff, our intent was to create so-called training that people would want to go to just to learn more, without any actual intention of becoming a speaker or a conversation ninja. That we want to serve both purposes. We thought that they were compatible, so that's very important, Kate. I know in my chapter now wants to set something up, and that's not going to be because everybody wants to be a presenter. It's because they're hungry to learn. I think the state's full of people who are hungry to learn, and if they come to a ninja training to learn it, that's okay with me.
Lou's got his hand up.
Yeah, just quick. So as we run into people that we think are maybe a good speaker or whatnot, shall we send them to you, Sandra?
Yes, send their name, the phone number, the email to me or to Mike, and we will keep building up this list.
Okay.
I have not run this past Mike and John, but I think that after today, we will be ready to put together some kind of event for newbies, not just for you all, the experienced ones, but for people who are fairly new to HCAO, I would say, which would include people who are also fairly new to presenting, but also the people who think they're already excellent presenters, just need to know a little more about HCAO. So we'd have that going. I think we could do that fairly soon. Everything in this is iterative, though. Every single thing we do could be better, and we have to keep doing it where we're at and trying to make it better the next time. And maybe by the time the ballot measure comes around, we'll know what we're doing. Nobody wants to. Who wants to talk?
Well,
we lost a few folks.
At some point, I want to let people see what else is in the slide deck, and also how to navigate the Google Drive to the what we've prepared. But I want to leave it to you when to do that, if at all.
What we have done is we've set up our Google Drive outside the HCAO drive, so that we could put people on it without having to put them on the whole HCAO network with access to everything, including the financials and the fundraising and all that stuff. And so as of now, we can put people on, give people access to the materials we've put together that could be accessed online. But we need to talk some more and figure out where it should be housed. Right now, Mike is the owner of these things, and I think there's probably a limit, Mike, to how many bytes you can have before.
I have plenty of room.
You got plenty of room. Okay. So that's what's probably going to happen is they're going to, we can, it's about almost a 2:45. We've lost a bunch of people. We ought to make sure we've done what we need to do before we leave for the day. One thing I want to be sure to get in is to thank everybody for coming and helping us. But I also want to leave a little time. Is there anything else you want us to keep in mind as we're preparing the next iteration of this ninja training? I don't know. Or anything that happened today that you want to underline as something that we should be sure to do or not do?
I haven't, I haven't seen the whole slides, but with the loss of doctors, it's becoming a big issue. There's a whole change going on. People that had doctors before now have PAs. Is there any information? I mean, I looked up ratio of doctors. We seem to be in the ballpark in America. But is there any facts and figures that would show this change and loss of healthcare providers?
I'll try to look that up. Certainly we're low on primary care compared to other countries.
Yeah.
Karen's got her hand up.
Well, just as a comment, I think we should be very careful to avoid using national statistics when we're trying to talk to people about the Oregon solutions. Because we have taken many steps through the Oregon Health Authority and the expansion of our Medicaid waivers to whittle down to between 5% or so of our population being uninsured and not having healthcare access. That's a very different story than you find nationally. And the same with the ratios of doctors and providers. And I think it also varies in areas of the state. And we need to be cognizant that we've got, at least from what I hear in the news, bigger problems in Eastern Oregon than we have here in the Willamette Valley.
Yeah.
So let's try to dig out the data that we can, and that's really pertinent to our audience.
I agree. Included in that is local data on how much cities, counties, schools are spending on healthcare. That's persuasive. When we can show that those costs would go down as well.
Charlie.
I want to just caution us on what Mike just said, that we don't know what the tax structure will be yet. That's part of what the Finance and Revenue Committee is going to be doing. And so I don't think we can say with any assurance at all that the costs for cities and schools will go down. It may end up being that we need to charge them about as much as they are now in order to have a tax structure that can be acceptable. So I think we ought to be real cautious about some of those kinds of things.
Okay, thanks. Kate's got her hand up.
Yeah, I think the other thing that I hear talking to people that they're afraid of in terms of providers is that a whole lot more people will be covered and there won't be enough of them. That I hear that expressed a lot.
They think people will lose coverage under the single payer system?
Yeah.
What?
Yes.
Because you're diluting the care. There's a shortage of workforce, and they'll take away my access to my doctor.
Oh.
And I would add, I'll add to that because the intent of the system we're putting in would have the same reimbursement rates no matter who you're providing care for. Essentially, patients would have the same reimbursement rate for providing care to them as for private insurance. So it's not just the lack of the diluting because of more people getting care. It's also diluting because now there's no incentive for those providers to provide care to you rather than somebody who's on Medicaid. For those who actually do have private insurance and say, I love my private insurance and I want to get the best care and I don't want it. So I think that's also of fear that we need to be aware of might be out there.
Does anybody know what they mean when they say, I love my private insurance? What do they love about it?
The fact that they have it.
Well, they like
And it
it.
covers things.
No,
Yeah.
I've talked to people, normally they're fairly healthy. So they don't have to go to the doctor a lot. And when they do, it doesn't cost them anything, or it costs them $1 or whatever, right? And so they're happy with it, right?
Yeah.
I mean, you got people in the VA and TriMed, right? TriMed, and they're happy with it. Gee, I had to pay $6 for all my drugs last month. Thanks.
So,
Right?
so I'm, uh, uh, please help me with my confusion. And the people often say things that are just wrong, like, keep your government hands off my Medicare. That's what the Tea Party
Yeah,
used to
right.
say. But people, when people say, I love my private insurance, I love being able to choose my private insurance, are they really saying, I love my doctor? I love being able to choose my doctor?
I would say more people are saying not so much that they can choose their private insurance, but I have chosen it and it's worked for me.
Yeah.
Or my employer chose it for me.
Well, I mean, I'm not necessarily that, or
Okay.
I mean, there's lots of varieties of that. I mean, some people, even like their Medicare Advantage they've chosen, or they like their
Yeah, my neighbors.
Medigap plan that they've chosen, or whatever. I mean, so I think sometimes it's just that it's worked for me so far, and I don't have to pay. I pay almost nothing, and so I'm fine with it. And so I would be. I'm not sure what's going to happen when you do your plan. So I think it's just a fear and seems to be working for me.
Yeah, I will add, just remember, most people are healthy most of the time. And remember that 90% or 95% of the healthcare costs happen in the 5 last years of a person's life. I mean, it's an uphill battle when you're talking to a lot of healthy people who just really don't pay any attention, don't give a shit.
No.
Yeah.
They might be impressed by the amount that their employer is paying, which is basically what they are paying as well, because that's part of the benefit package. And some, Karen,
But I think we have a real difficulty in convincing people who are paying, let's say, $400 a month for their family coverage under their employer's plan, and appreciating that other $2,000 a month that the employer is paying, and they don't see it as part of the cost. And nor should we try to tell them that that they will achieve that in
Right,
wages
right,
if we change the system, because there's no guarantee
no
of that.
guarantee.
And that's, I think, where the big gap is going to arise in terms of the amount, if we have an income tax based system on individuals that will double or triple their Oregon state income tax and equating to what they were paying for premiums. And many of them with healthy families don't have that much out of pocket expense to contend with. You know, we have to help people look at the what ifs.
Yeah.
And that's hard. That's hard to trade something that's not costing that much with some speculative what ifs. Your kid gets in a snowboarding accident and winds up in the hospital for 12 days like mine did. That's hard to imagine.
And you don't want to imagine that.
You don't want to, it's hard to. And you don't know what all those costs will really be when all the bills come in.
Yeah.
So
I think that's where we need stories. And I'm less concerned here with personal stories than I am with heartrending stories. I don't care what part of the country they come from, but a story or two about somebody who had a terrible catastrophe and whose health insurance turned out not to work.
Yeah.
I mean,
And
people need to have their emotions stirred up. And I was just reading today about political messaging. It's good political messaging stirs up good emotions, like I share these values and I like these people and this is my movement. And it can also stir up bad values, and we can be bad emotions. We can be part of the process of making people feel both bad and good emotions as long as they attach them to the right attachers.
Lou got his hand.
Yeah, I just want to say that, the answer for workers who their employer is paying a portion of their health care and they don't realize it, or health insurance, is that the amount that employer is paying is an amount of money that's not going into your wages.
Mhm.
That's pretty simple math, right? So people catch on. I mean, they go, yeah, that's right.
In honoring Karen's caution is that there's no guarantee that money would go to them.
That's right.
But it still should impress them, I would think.
That's right.
I think that W-2 statements have a place on them where they indicate how much your employer is paying for your healthcare. And so that's one of the things we need to,
That's a good
for
point.
people who are interested enough to look at a calculator, I think that's one of the things we need to make sure that they're aware of. So
Good point.
make use of that information.
Karen's got her hand up.
I hate to caution too much, but for people who have their wages direct deposited into their checking account and are short form filers, it's going to be hard to get them to pay attention to those deep numbers. I've been playing with a form that we developed at Mid Valley in 2019 to try to have people put down their best estimate of their costs for private insurance, Medicare Advantage plans, and Medicare. And it will perhaps be helpful if we can get this put together and be able to circulate this to people so they do have the opportunity, not especially at this time of year, which is tax time, to think about it when they get their end of year statements. But I think a lot of people are really quite oblivious.
So one of the things we need to do is to prepare our ninjas to respond well to the question, what's it going to cost me?
Yes.
This is one of the things John Ricker talks to us about a lot. And I know there has been considerable effort to try to construct a calculator or teach people how to calculate what they're paying now and what they might pay under a publicly sponsored system. But I'm wondering if it might not be just as effective, at least for the next year or so, to have case studies that our ninjas can present. They could say, you want to know how much it'll cost you? Well, you can go to such and such website and make your own calculations. But let's look at somebody whose situation is sort of like yours and look at kind of what they're paying now and what they would pay. And this is kind of, by analogy, that might tell something about what you would pay. Do you think that would be effective for the people whom we are trying to persuade to support our movement?
Simon, did you have your?
No.
It wouldn't work? So are you saying no, it would not work?
Well, we tried to work around with that concept, and there are so many variables for individuals. We even tried to highlight, at a couple of age groups at different income levels, homeowners, renters, and it just got to be nightmarish to try to come up with that. So maybe someone smarter than me or the group that we were working with could come up with something, but it's hard.
So I will say the task force did a little bit of that, but one of the issues is that to make it at all realistic, you need to know what the tax structure is going to be, and we do not know that. We haven't even presented a possibility in the Finance and Revenue Committee of the Governance Board, and the one that was presented as a possibility by the task force, I think I'm hoping we go way away from that. I think it was terrible. So I think that we have to make some assumptions that we have no idea if they're right or not at this point. Maybe in 6 months, when the governance board or the finance committee has gone a little bit further along, we might have better ideas. I would also say that one of the jobs of the Finance and Revenue Committee is to try to come up with a calculator of the sort that you're talking about at some point, but we're not anywhere close to that again, because we don't have any tax structure there.
Okay, so what can we say? We're gonna have people asking that question in March of 2025. How do we respond?
Maybe we honestly say that that is the big question. We recognize the importance of answering it, and that the governance board who is charged with that task is working on it. And it will need the work of the subcommittees and consultants to come up with that answer.
I think it's
I would also say that we could say something to the effect that unless you're high income, it will almost surely cost less than what you and your employers are putting in now. That's about as far as we could probably really go with any reasonable accuracy.
Well, tell me if I've been thinking that, well, generally I rely on the task force until it's superseded, but, which I guess it will be. But what if we said the cost of healthcare for Oregonians is predicted to drop by $1 billion from like 21 billion to 21 billion to 20 billion. There's $1 billion in some
55
part,
to 54.
55 to 54. Some part of that $1 billion of savings may very well be yours.
Right.
$1 billion sounds like a lot of money to people.
Not anymore.
And that's $20 a month if it on the average for an Oregonian.
Lou's got his hand up.
Yeah, that's a good question, and it never looks good that we don't have the answer, right? But we can let them know that the governance board is working on the answer. But common sense will tell you, we know that 20 to 30% of the health care that we're getting now is the cost is due to administrative costs.
Yep.
Just to administer all these health insurance plans. So we know that we will save a great, at least 20% of that right off the top. And you can compare that kind of stuff. Plus, you're taking profit motive out of the system, right? So we know that will level off the costs in the future. So I don't know. Common sense will tell people once they know a couple of facts about this system is that it will save money and it will cover everybody, which right now it doesn't.
A problem is that the same people who insist, what is it going to cost me? What is it going to cost me? They are often the same people who say, I don't want to pay for somebody else's health care. I don't know quite what response to that to recommend.
Well, our system is we are already paying for other people's health care, and it's not a bad idea. I mean, the COVID epidemic taught us that the more people that were vaccinated and cared for, the less other people got sick. So
rather than
I would go back to that.
Rather than take time to look at the other slides, I just encourage everybody to look at all of the slides and see if there are slides that you would want for a particular audience that isn't in the first 40 or so. So I hope you can do that. And then if you want help navigating to these on Google Drive, just let me know and we can do it together on Zoom or something. Is that right, Sandra? Yeah.
Yeah.
Well,
we've got a very small group here.
Yeah, I gotta go.
Our team members and 3 more, but certainly if you're getting ready for an event and you want some help from anybody on this team, don't hesitate to ask.
All right.
Mike and I will do whatever we can.
This has been very informative. I've really enjoyed it. And it's given me more hope for the future than I had before.
Well, it's been very informative for me. I love when I learn, and this has been one of those days. Thank you.
All right. Thank you all.
Yeah.
Thank you, Mike and Sandra, for setting this up.
Yep.
Thank us for 10 months of good hard work
God. Super, right?
so far. So far, we got chains around our ankles. We gotta
Hat
keep
goes
doing
up.
it.
Oh, this is a great start. Great start.
Okay, all
Thank you.
right.
Bye-bye.
Goodbye.